Yes, it could have been much worse, I admit. I was very lucky. Everyone was lucky. It sounds trite as I hear myself. How are you feeling? She's not asking to be nice. What she's really doing is make morning.
Hi,
Hi, how are you?
making dinner.
I understand. Right, let's give people another minute and just see if we can get maybe a few more people. First, any questions or concerns?
When was the exam number 2 due? Was that due this week or is that due next week?
Let's say next week. I think we said the 20th, I think.
Oh, okay. I took it today and I passed and I was like, oh, I didn't even know.
Awesome. Okay. Well, do you want to get better score? Take it again.
No, I got
I think we agreed on the 24th.
Yeah, the 24th. Okay.
All right.
Okay. So kind of having a discussion after class the other night. All of your assignments, except for your Wiley lab exercises and your 5th lab quest.
No, I'm on time.
Actually, maybe your 5th lab.
No, you're not, because
I'm
you're
on time. I'm just not sitting in front of the computer, but I'm on time. It's 6 o'clock.
Oh my gosh, Mom.
She froze though.
That doesn't count.
We're not dissecting any animals today, are we?
Okay.
I think you're muted.
I'm sorry. I muted someone else and accidentally muted myself in the process. I get, we don't have anything to dissect tonight. Well, I mean, we if I'd had a chicken bone leg or chicken on hand, we could have done some, but I don't have any right now. I think we set it up the other night, and I set it up so that bear with me. I'm coming into McGraw-Hill to remember what I did. When it comes up.
Pastor Gressel, I wasn't sure if you got my email from either last week or beginning of this
I
week.
saw something from you and I thought I responded, but I may not have.
Oh, okay, because I was trying to finish the Smart Book chapter 13. And
Okay.
I wasn't able to do it because it said it was already due. And I was asking for an extension on it. And
I think you can have it done.
I can have it done probably by tomorrow.
Okay, how about I give you until Friday or Saturday?
Okay, thank you.
Okay, you know what, I'm just gonna do it right now while we're thinking about it. Okay. Okay, it's done. Yeah, I saw it. And then I thought we talked about, I thought we talked about it the other night, and then I didn't think about it after that. So I apologize. Well, what was I doing? Okay, now I remember. So so a group of us talked after class for a little while. And a couple people said that it would be easier to just open up the majority of what will be due between now and the end of the semester. And so what this means is that all of your virtual labs that you have one tonight, and then you had 3 more that would come within the next 2 weeks. They're all open for you to do now if you want to. They're related to joints and movement and muscles. And they'll be open through the May 6th. So a little bit less than a month. The 4th lab quest is open now, and it will be due in about a week, on April 19th. Your second exam, like Sam said, is due on the 24th, or Lauren asked, it's due on the 24th. The other 2 are due on the 6th. And you know what? I think I was gonna actually set out the final, which is comprehensive. The final, so that it would actually go, bear with me here, assignment options. I think your the syllabus says that the final for this class was scheduled to be the 9th. And so let's set it up so it's due on the 9th. So when you see all these due dates and you see that they're all open, don't let it make you crazy. We still have almost a month before school's done. And I just got asked by a couple of students if I would just open up most of what you have. The last part that you don't have yet is the 5th lab quest and the Wiley lab exercises for the next 2 weeks. All 3 case studies are underneath. If you haven't submitted those, please get them submitted before the end of the semester. I know I have not graded them yet, but if you don't turn them in when they get graded, you will get a 0 for them. And they are worth about 10% of your grade. Any other questions, thoughts? Let's jump into tonight. So tonight's
I'm sorry,
lab
I have a quick question.
goes in
So to get if you get the 1200, is that A automatically, or you have to get, is that like, what is a C?
let me look at the syllabus. Bear with me just for a second here,
Okay.
because I have to remember myself. Yeah, remember I have 6 classes, and so the syllabi are different for every class. So I actually have to look at it I look at it pretty regularly because I don't remember all the time the specifics for each class.
I understand.
So if you get 1250 points, yes, any percentage over that or less than that, 1250. So for example, you get 1150 points out of 1250. Whether you got those points from the extra credit or from the assignments, it doesn't matter. So 1150 points divided by 1250 would say that you'd have a 92% in the class. And according to Hack's grading system, that would be an A.
Okay, thank you very much for explaining that.
Of course. Any other questions, concerns, thoughts? Okay. So lab exercise, that wasn't what I meant to click on either. Bear with me. One of those moments. I didn't mean to click on the exercise. I know there's a PowerPoint because I was just looking at it. So this lab exercise is over 11 and 13. We're just going to go through lab exercise 13, which is joints and movement. And then we'll do the second part of this next week. So joints and synovial joint movements. So a joint is defined as a place where a bone meets another bone, cartilage, or teeth. Articulation meaning to move. Some joints are movable, some are not. joints can be classified based on their structure and their mobility. And they're classified into categories based on these characteristics. The more mobile a joint is, the less stable it is. The less mobile a joint is, the more stable it is. Some good examples of this concept are the sutures in between the skull bones. These are joints, they don't move. They're exceptionally stable. The shoulder is extremely flexible, but it's also very, very, very unstable. If you think about it, you know at least one person who's had a shoulder injury, if not more. Because it's a very unstable joint. And most of the things that connect them, the ligaments, the cartilage, the fibrous tissue, are very avascular, which means that when they get injured, they take a long time to heal. So classifications. They're structurally classified based on the types of material that bind the bones together and whether there's the presence of a joint cavity or not. Structurally, they're classified as being fibrous joints, where the joints are held together by dense, regular connective tissue. Cartilaginous joints, where the bones are held together by cartilage. Or synovial joints, where the bones are actually separated by a fluid-filled cavity. Fibrous joints, very immovable. These would be like the bones in between the skull plates. Cartilaginous joints, like the intervertebral discs, semi-movable. Synovial joints are freely movable. So functional classification. Fibrous joints tend to be synarthrotic, meaning they're immovable. If you think about what SYN means, to bring together, SYN, meaning to bring together. To the point of where it's permanent. Amphithotic. You guys remember, what does it mean to be amphiphilic or amphipathic? What does it mean to be amphiphilic or amphipathic?
Is that where you're outside, you're like a man, but your insides are a female?
Nope, that's a hermaphrodite. What, if something is partly hydrophobic and partly hydrophilic, it's amphipathic, or amphiphilic. So what this means is that it's somewhat movable, somewhat flexible.
Oh, I see. So like amphibian.
Amphibian, I don't know where they get their name from.
Oh, because it seems to make sense, like both in and out of water. They do.
I well see that I get that's probably where it came from. I don't know a lot about amphibians except I don't like to be in close proximity to them because they move fast and scare me. But you're I'll bet you money that's where the name comes from. That sounds really quite good. I did not know that. So somewhat, one way or another. So somewhat movable. That's neat. I didn't know that. Amphibian. Okay. You know what? I will have to. I'm making a quick trip down to Southern Virginia. Not tomorrow, but the day after tomorrow. And my nephew is big on amphibians. Their whole family's big on amphibians. And I may have to bring that up when I'm down there. Last one, dia, meaning very flexible. So looking back at this, synarthroses are immovable joints. Fibrous joints tend to be immovable. Amphithrodic joints are slightly movable. For example, the pubic symphysis. Another place, the cartilage that connects the ribs to your sternum. Another place, your intervertebral discs are all amphithrodic joints in that they're somewhat movable. Diathrodic joints are synovial joints. So synarthrodic joints, fibrous joints. Amphithrodic joints are cartilaginous joints. Diathrodic joints are extremely movable, synovial joints. And I think I'm going to write that down actually. These are just generalizations. So synarthrodic joints are synarthrosis joints. Tend to be the fibrous joints. Amphithrodic joints or amphithrosis I'm thinking I didn't spell that right. I don't think I didn't spell it right. There. Still don't think that's right, but I'm going to leave it the way it is.
PHIA.
Say it again.
PHIA.
E.
AMPHI. You're missing the I
Right here
before the A.
before the A.
Yeah.
Okay. All right. Well, I should have noticed that with that up there. All right. Tend to be cartilaginous joints. cartilaginous. I don't spell it right. O-U-S. And I know that isn't spelled right. I think this is supposed to be an E. That doesn't look right either. I think that's right. I think so. And diathrosis. Write these down. I teach an anatomy course at Stevenson in the fall semesters. Their physiology and anatomy are two different classes. And so mostly you have anatomy in the fall and you have physiology in the spring. And this is something that I've just recently connected these, made these generalizations in my head. And I told them that last semester, if I could figure out a way to make generalizations in my head, I would write them down. And the more I look at this material, the more I'm able to make those generalizations, which is what I'm making for you right now. So write them down, just for me, to make my life a little easier and possibly yours too. Synovial joints. So this is a structural, functional classification of joints. And this is a structural classification on the other side. And this is how they relate to one another. So synarthrotic joints tend to be fibrous joints. Amphiarthrotic joints tend to be cartilaginous joints. And diarthrotic joints tend to be synovial joints. Because we're going to talk about a lot of terminology here. And so if you get this terminology right, it'll make your lives easier. So fibrous joints are where the bones are connected by dense regular connective tissue. They don't have a joint cavity. There's three basic types. There's a gomphosis, a synostosis, and now I have to remember what the third type was. Gomphosis, synostosis, and shoot, I can't remember what it is. Gomphosis, synostosis, synarthrotic. No, that's not right. Fibrous. All right, I'm gonna have to look on the next set because I cannot remember. A suture, an easy one. So gomphosis, meaning your gums. This is the only gomphosis one you have. This one right here. Next ones are fibrous ones. Your next ones are sutures. The easiest way to remember the gomphosis is that it's your gums that keep your teeth connected in your gums. Synostosis. So gomphosis, sutures, and synostosis. Those are the three. Synostosis are the binding of two bones together by a membrane, such as the interosseous membrane. Bear with me one more time, because I couldn't remember them. And so let me tell you what they are. Fibrous joints, include gomphosis joints, sutures, and synostosis. Synostosis. Gomphosis, teeth in the jaw. The joints that are holding the teeth in the jaw should not be movable. Sutures, between the cranial bones, such as the frontal. Actually, let me put like the sagittal suture of the skull. A synostosis joint would be the radius and the ulna. Ulna. And the interosseous membrane that binds them. Membrane that binds them, binds the two bones together. It's the same, you have that same synostosis between the tibius and the fibula, between the tibia and the fibula. The synostosis. Did you get those written down, Marissa, since I know you're writing them down? Did you get them?
The last one, I didn't get all of it after the membrane.
That binds the two bones together.
Okay, thank you.
Well, so this interosseous membrane is not flexible, and it can be between the tibia and the fibula. It can be between the radius and the ulna. I am still thinking in my head how it's not flexible, because in my head, I know that at least in the radius and the ulna, maybe not in the tibia and the fibula, but right here, the radius moves over the top of the ulna. So in my head, I think that membrane, that joint has to move a little bit.
Maybe
But
more of the movement is happening at the elbow joint instead
Because-
of like,
where the head of the radius is and then it's rotating across.
yeah, potentially.
But it wouldn't move this either. It wouldn't move this at all.
There.
I mean, if I do this with my hand, it doesn't move it across at all.
I guess doing it on myself here, it does. So I don't know.
Yeah, I don't know either. I know that's what they say. So that's the way we classify them, but that one looks like it's fairly movable to me in comparison. I mean, you can't really do that with your fibula and your tibia, but you can do it with your radius and your ulna. And you know what? And I was wrong. I knew that I didn't have this name right. So this synostosis, it's actually, and it might be called both. It's a syndesmosis. And it may be that it's got both names. I'm not positive about it. I think most textbooks refer to it as being, it might be interchangeable. It might be. And I can't remember exactly how your textbook refers to it. Cartilaginous joints. Have synchondrosis joints that contain hyaline cartilage. And the symphysis joints that are amphiarthrotic. So here we have synarthrotic and amphiarthrotic joints. So now I need to adjust my labeling that I had my classifications before. Bear with me just for a second here. Because I had these classifications all set up, and now with just looking through this PowerPoint, I'm realizing I've got to rearrange them a little bit. Synarthrotic is fibrous. Cartilaginous, I think that's actually supposed to be an I there and not an E. But these can also be synarthrotic. Or synarthrosis. Yeah. So cartilaginous joints can be synarthrosis or amphiarthrosis. But they tend to be amphiarthrotic. Synovial joints, I'll assure you they're always diarthrotic. So fibrous joints are always synarthrotic, meaning that they're immovable. Cartilaginous, and I think that E is supposed to be an I. Amphiarthrotic or synarthrotic joints. So they can be somewhat movable, flexible, or completely unflexible. Diarthrotic joints are always synovial joints, and they're always as flexible as they can possibly be within the restrictions of the bones themselves. They're only restricted by the structure of the bones making them up. And we'll see that in a moment. So synovial joints are articulating bones that are separated by a joint cavity. They're always diarthrotic joints. They have an articular capsule. So they're surrounded by a fibrous capsule that contains a fibrous layer and a synovial membrane. So bear with me, just I'm going to flip around a little bit. I'm going to draw a joint because for me, sometimes, especially with anatomy, and I suggest you do the same thing. But drawing, regardless of how bad of a drawer you are, drawing will help you remember structures better than just seeing pictures. So I have 2 bones here. And around every synovial joint and encompassing every synovial joint is an articular capsule. So right here, moving down right here, both sides, this articular capsule, and it's got 2 layers. The outer layer has the fibrous layer. And the inner layer, which I'll draw in a moment, the inner layer is the synovial membrane or synovial layer. So very right inside this fibrous layer is the synovial membrane. And it's the inner one, and these 2 together are the articular capsule. Like so. Now, coming back to the PowerPoint. The outer fibrous layer is made of dense, regular connective tissue, and it's going to serve to strengthen the joint. The synovial membrane is going to secrete synovial fluid, this lubricating fluid. Synovial meaning wet. It's a wet fluid. And the articular capsule is going to surround a joint cavity that's full of the synovial fluid that's being secreted by the synovial membrane. So I'm going to come back into my drawing just for a minute. So inside here, my joint cavity. I can't type joint cavity. That is filled with synovial fluid. Fine. Lining each of the surfaces of the bones is articular cartilage, which is made of hyaline cartilage. Oh, that's not what I meant to do. So lining both ends of the bone. Yeah, I'm not paying attention that way. I don't know if you can hear my cat meowing. She's my demanding one. Are you going to squawk so they can actually hear you? So it's going to line the surfaces. What is hyaline cartilage? What do you remember about hyaline cartilage?
Isn't it like glassy?
It is. Good job. It's glassy and it's very, very smooth. So this articulating cartilage is really, really smooth to allow to reduce friction and also work as a shock absorber. So synovial joints are lined with hyaline cartilage that works as a shock absorber. The joint cavities filled with synovial fluid, and it's going to and the fluid is going to lubricate and nourish the articulating cartilages, nourish the chondrocytes. What are chondrocytes? What does chondro mean? It's been a while. Cartilage, good job, cartilage. So synovial fluid is going to nourish the chondrocytes of the articular cartilage and absorb shock during the compression of a joint. Ligaments are also going to connect bone to bone and be dense regular connective tissue that's going to strengthen and reinforce the capsule. And it contains sensory nerves and blood vessels. So I'm going to stop my PowerPoint again and finish my drawing here. Good color to use. Let's use this one. We'll use this one. I haven't used that one yet. So lining the articular capsule are ligaments. This is the ones that you tend to see. But realize that underneath them are the articular capsules. Remember the difference between ligaments and tendons. Ligaments connect bone to bone. Ligaments bone to bone. Tendons, bear with me. Tendons bone to muscle. Really easy to get confused. And I don't know a mnemonic to keep them straight either, or I wouldn't know it better than I do. So ligaments strengthen the capsule and contain sensory nerves and blood vessels. Additionally, one other thing that we have in here is we have what are called bursa. And bursa are where would they be? Bear with me here. They're under the ligaments. Or actually, let's not even say they're under the ligaments. Let's say they're surrounding the ligaments. They can be under or above. And these are like fluid-filled sponges or gelatinous. Okay, it sounds terrible, but I don't know how else to call it. Women getting enhancement of their chest. I would think that these would look something like that. Those things that they put in there to enhance your chest. And I can't remember what they're called. I read books, so I know something about them, and that's about all I know.
Implants?
What are they?
They're just implants. They're like,
They just call them implants?
yeah.
Okay. Well,
They're either like saline or some type of like,
They're silicone.
silicone based.
silicone or saline. Oh, saline is probably safer for you if you're ever going to do something like that. But these would be like those. Have you ever heard of somebody getting a bursitis?
I've had, I know a couple of patients that have, and it's not fun.
Well, I've gotten one time, and I lived in an old building in Idaho, and it was an old building. It was built in 1912. It was old. And I was running down the stairs to go meet a friend and decided to pretend that the last two steps weren't there and forgot about them. And fell down and banged my elbow really well on a cement flooring.
It's so hard not to zone out.
And I just remember it swelling up. And I called my brother, who was a PA, and I said, what do you think I should do? And he said, ice it and heat it. Alternatively, so if every 20 minutes, I said every 20 minutes, heat it. And see if it will just go away and your body will reabsorb the fluid because you've got a bursitis. So And if it doesn't get reabsorbed, if the fluid doesn't get reabsorbed, a lot of times they have to go in and suck the fluid out and drain it. Thankfully, that wasn't what happened with me. It just went away by itself.
So at my job, I had a few times I got to work in the orthopedic clinic, and there's this gentleman. I'll never forget this because he, I guess, in his like patella area, the cavity was somehow leaking or it didn't have enough fluid.
Okay.
So it was kind of like bone rubbing on bone, they said.
Ouch.
So they had to use this, they had to order and put in this syringe, and it's kind of like a replica of the synovial fluid.
Okay.
And they had to put it in his kneecap, and the needle was just humongous that I had to use. And I will never forget the man. He was screaming so much.
I can't imagine that did not hurt. I was going to ask, how badly did that hurt?
He was screaming the whole time, and I will never forget that man's scream.
Well, because there's so many ligaments and tendons around there that have a lot of nerves. More the ligaments, but there's a lot of nerves in that area. Oh, ooh, blah. Yeah, that just sounds bad. Did it help? Do you know?
Well, he ended up coming back 2 weeks later to do a follow-up, and he said his legs actually felt better then because I guess it kind of put the fluid back in there so his bones weren't rubbing together. So he said he was feeling better, but he's just, I guess, hoping and praying it doesn't happen again where the fluid somehow leaks out or disappears.
Wowzer.
Because then he'll have to get it done again.
Wow. Yeah. Ouch. So yeah, they're little pads. And that sounds like it was a leakage of the articular capsule. Maybe not so much the bursa, but the articular capsule. But these are little pads, little sponges of fluid. So there's 6 different types of synovial joints. There's plane joints, hinge joints, plane meaning 2 planes together. Sorry, my chair's really squeaky. There's hinge joints like a door hinge. Pivot meaning one pivots around the other. Condylar joints or condyloid joints is probably my favorite one, but I know it makes my joint sore if I do it way too often. This little thing right here. How you can move that joint between the first metacarpal and the, what is it, the scaphoid, right there. How you can flip it. That's a condyloid joint. And you know what? And of course I messed it up. It's not a condyloid joint, it's a saddle joint. So it's this joint right here. It can go 2 different ways. And for me, that gets really sore really quickly. So I don't do it very often, but I still think it's fun to look at it and see that it flips around 2 ways. So pivot joints, condylar joints between the radius and the carpal bones, condyloid joints. Between the first metacarpal and the trapezium carpal joint is the one that I was playing with. the ball and socket joints, your hip joint and your shoulder joint are both ball and socket joints, where a ball fits into a socket. The head of a bone fits into a socket. So the saddle, the plane joint in between the carpal bones, plane joints. Plane joints in between the carpals, in between, where else do we have plane joints? Plane joints. In between the vertebrae? Maybe. I think those are plane joints. No, those aren't plane joints. I'm not going to try to guess more. I can't remember anyway. But saddle joints, the first metacarpal and the trapezium. Condyloid joints between your phalanges, phalangeal joints, and the metacarpal with the phalangeal joints. Hinge joints, your elbow, your knee. One pivot joint is between the C1 and C2. If you remember that dens that's on the C2 vertebrae, pivots on within the C1 vertebrae. So the dens of the axis is going to stick up in the notch in the C1 vertebrae and articulate. So looking at them some more. So plane are also called gliding or planar joints. Articular surfaces that are essentially flat. Another planar joint in between your carpals, and then in between the carpals and the radius and the ulna. Only allow for slipping or gliding joints. They're the only examples of non-axial joints, meaning that they're not moving on an axis. They're moving on a plane instead. Hinge joints, cylindrical projections where one bone fits into the trough-shaped surface of another, and the motion is along a single plane. They're uniaxial joints, meaning they only move one direction, only move back and forth, allowing for flexion and extension only. Pivot joints, the rounded end of one joint fits into the sleeve or ring of another bone. For example, how the head of the radius fits within the annular ligament. Are you going to get up here? Come here. The annular ligament that wraps around it that's attached to the radius, the ulna. So the head of the radius slips within this annular ligament to make up what's called the proximal radial ulnar joint. Proximal because it's a proximal end in anatomical position, and it's in the radius and the ulna. Most joints are named according to what they attach and what they connect together. Condyloid, or another name for condyloid or condylar joints, are ellipsoidal joints, where the oval surface of one bone fits into the depression in another bone. Both articulating surfaces are oval, and these permit all angular movements. So being able to do circumflexal, moving in a movement. Biaxial joints, meaning they move in two different axes. The radial and carpal joint, wrist joint. Or this. Saddle joints, similar to condyloid joints, but allow for greater movement. Each articular surface has both a concave and a convex surface. Like that carpal metacarpal joint of the thumb, the one that I said initially was a condyloid, that's actually a saddle. Ball and socket, your least stable joints, but also your most flexible. So the spherical or the hemispherical head of one bone is going to articulate in the cup-like socket of another. These multi-axial joints are going to permit the most freely moving synovial joints. Examples are between your shoulders and your hip joints. And I'm going to stop just for 1 second, and we're going to watch a quick video here. Maybe. Leo, don't get up there, buddy. No, don't get up there. Sorry, talking to my cat who was wanting up on the table right onto the laptop.
We can't wait to be doctors. Be aware of that all these joints have. First thing is, hi everybody, Dr. Mike here. In this video, we're going to take a look at synovial joints. The first thing you need to remember is that there's three major joint types in the body. There's fibrous joints, which don't really have much movement. There's cartilaginous joints, which have a little bit of movement. And there's synovial joints, which are freely movable. So the focus of this lecture is going to be those synovial joints. If we were to take a stereotypical or general synovial joint, which I've drawn up here, there's a couple of things you need to be aware of that all these joints have. First thing is, when you've got one bone articulating or speaking to another bone like we've got here, there's going to be cartilage lining the surface of those bones. This cartilage is called articulating cartilage, which basically means communication cartilage. And the type of cartilage that's present is hyaline cartilage. It's there because it reduces the friction at the site where that first bone talks to the second bone. The other thing that you're going to find is that all synovial joints will have a synovial capsule, also known as an articular capsule. Now, that contains two particular things that you need to be aware of. One is that there's a fibrous layer, which we can see here. This is dense connective tissue, really important because it holds that joint nice and tight. Second thing is there's a synovial membrane. This is on the inside of that joint, and it has simple squamous epithelia. Now, squamous, remember, squished epithelia, it produces.
You guys,
the fluid in the-
what's simple squamous epithelium? Or squamous, how I say it.
One stratified, that's like flat.
Yep.
Cell.
Yep. One layer of flat cells.
Fluid is called synovial fluid. So you've got synovial fluid in the joint capsule itself. And what the synovial fluid does is, one, creates this frictionless environment, similar to what these articulating cartilage surfaces are doing on the bone. Two, it provides cushioning so that when there's some sort of impact at the bone, it helps reduce that force. And three, it helps deliver nutrients and takes nutrients, or I should say wastes, away from the site. That's what the synovial fluid does in the joint capsule. So as you can see, that's a generalized view of a synovial joint. So one, they're freely movable. Two, they have articulating surfaces with articulating cartilage, which is hyaline cartilage. Three, they have a capsule which has a fibrous layer and a synovial membrane that produces synovial fluid. Now, there's 6 different types of synovial joints that you need to be aware of. And they can be basically categorized as being uniaxial, meaning it only moves in one plane. Biaxial moves in 2 planes, and multiaxial moves in more than 2 planes. So I'll talk about this in more detail in a second, but let's go through how we can remember the 6 different types of synovial joints. So luckily, I've created a mnemonic for you, and this mnemonic is Prince Harry pulled Charles's saddlebag. Now you can interpret that any way you like. It doesn't matter. It's a mnemonic. It just helps us remember something. Prince Harry pulled Charles's saddlebag. All right.
You guys, can you guess what joints those are? Prince Harry. What would the prince stand for? What were the 6 different types of joints?
Prince would be pivot, right?
Right. What would be the other P? Or actually, let's just go with Harry. What would be the Harry one?
Hinge.
Hinge. What's the other P?
Proximal radial ulnar.
Nope, nope.
Oh. Plane.
Yep. So pivot, hinge, plane, Prince Harry pulled. Oh shoot! Now I gotta remember. Charles is okay, as it says right there. Charles is so
condyloid.
Right. What's saddlebag?
Saddle joint. Oh, saddle and then.
What is the B? Saddlebag. The B is another one.
The bursa.
Nope.
No, nope. Sorry, looked at the wrong paper.
Yes.
There's a ball and socket.
It is, it's ball and socket. So Prince Harry pulled Charles's saddle bag, put a space in between those. Pivot, hinge, plane, condyloid, saddle, and ball and socket.
Remember, what a mnemonic is you can take the first letter of each of these words, and that's going to tell you the first letter of each of the words we need to remember. So the 6 synovial joints, 1, 2, 3, 4, 5, 6. So what are the 6 synovial joints? Well, they're going to be, P is going to be planar. It's a planar joint, that's the first one. H is going to be hinge. It's a hinge joint. P is going to be a pivot joint. C is going to be a condylar joint. S for saddle is actually going to be saddle. That makes it easy to remember. Saddle joint. And B is a ball and socket joint. So there's 6 different types of joints. Planar, hinge, pivot, condylar, saddle, ball and socket. And the great thing is it goes from being uniaxial, biaxial, multi-axial. So let's actually highlight those. The first 3 here are uniaxial. Only moves in one plane. Condylar and saddle, biaxial. Moves in 2 planes. And ball and socket, multi-axial. Moves in many planes. All right, now let's draw them up, have a look at the different types. So first we're going to look at is going to be a planar joint. Now, an example of a planar joint first is that if you take the hand, take the bones of the hand and you have a look at all the bones of what we've got the carpals here, and you take the quadrilaterum and the hamate. Now, these 2 bones, their articulating surface is going to be that of a planar joint. And what does it look like? Because that doesn't really show it too well. It looks like this. You have one flat surface and another flat surface. And again, it only moves in one plane. And this is going to be a planar joint. So it's like a gliding joint is another way of explaining it. So the quadrilaterum and the hamate. Let's move on to the hinge joint. Hinge is simple. It's like a door. How a door opens and closes. And I'm doing that with my arm, funnily enough, because my elbow joint is a hinge joint. So let's take a look. I've drawn the humerus, the radius, the ulna, and here's the elbow joint. And again, unsurprisingly, you've got the articulating cartilage here. I haven't drawn up the synovial joint aspect or capsule because it just makes it a bit more difficult. But this is a hinge joint. And so if I were to draw a hinge joint up, a hinge joint is going to be like the hinge of a door, and it only moves in one axis. Hinge joint, perfect. Next one we need to look at is going to be a pivot joint. Now, a pivot joint, and the example of it here is the first and second cervical vertebrae, which is C1 and C2. I'll talk about that in a sec. It's where you've got a rounded bone, and that rounded bone sits within a circular bone or ligament. In this case, for C1, C2, it's a ligament, and it can only move in one axis. It spins, turns around. So what happens in this case is C2, your second cervical vertebrae, known as the axis, has a protrusion called the dens, and it sits underneath C1, which is known as the atlas, and that dens moves up and through, and you've got this ligament here. And what it allows is for the head to turn. So axis, which is another name for C2, means turning, spinning, right? Because that's what that one does. Atlas does it. And Atlas is named after that god that's holding the world above its head, meaning the head, the skull, right? So that's the Atlas. So that's an example of a pivot joint. Now, what we've drawn up are all the uniaxial joints, right? We've got the planar joint at the triquetrum and the hamate, and it just glides. We've got the hinge joint at the elbow, and it just swings open and closed like a door. We've got the pivot joint at C1 and C2, and it just turns around. These are all the uniaxial. Let's move on to the biaxial. Biaxial, first of which is going to be the condylar joint. Now, the condylar joint, the example is at the metacarpal and the proximal phalanx from 2 to 5. 2 to 5. So, The way that this condylar joint works is similar to a ball and socket, similar-ish, but definitely not as deep as a ball and socket. And we haven't done ball and socket yet. And again, it moves only in two axes. So if it was one axis or axis, it would be like this, but it's two. Okay, so it's two different planes in which it can move. And again, the example is the metacarpal and the proximal phalanx. That's the condylar joint. Then we move off to the saddle joint. Now, the saddle joint is like sitting on a saddle. Right? An example of a saddle joint is the trapezium and the first metacarpal. And a saddle joint, if I can draw it up, it's actually quite difficult to draw. That's a saddle joint. We've got those two surfaces and they can move in two different axes. Saddle joint. Again, trapezium, first metacarpal. Now we move on to the last of the synovial joints, a multi-axial joint. That's going to be a ball and socket joint out of the hip, where the femur articulates in to that hip joint. And we know that this is a great example. It's a nice deep joint, and because it's a deep joint, you've got that room for movement, and it's a pretty strong joint as well, but it moves in not just two planes, but it moves in many planes. And this is going to be a multi-axial joint, that where the femur articulates in at the hip itself. So let's just quickly label to finish off, right? So we've got the planar joint, at the triquetrum and the hamate. We've got the hinge joint at the elbow. We've got the pivot joint. We've got the pivot joint up here at C1, C2. We've got the condylar joint, which is going to be at the metacarpal and proximal phalanx. We've got the saddle joint, which is going to be at the first metacarpal and the trapezium, and we've got the ball and socket joint. Ball and socket. And these are the 6 different types of synovial joints that you need to remember.
Let's take a 10-minute break and come back to this, and we'll finish up. Okay, let's jump back into this. So just some examples of these different synovial joints. That proximal radial ulnar joint, what type of, oh, well, it says right there, it's a pivot joint. So the head of the radius is going to pivot within this annular ligament. Allowing you to pronate and supinate your arm. The hinge joint of your elbow, the humerus trochlea of the humerus sits within the trochlear notch of the ulna. Another example of a hinge joint. I picked these joints specifically because they're on your questions. The movement between the talocural joint, which means between the talocural joint, meaning between the tibia and the talus. So this right here. Allowing you to, we'll talk about these movements. Actually, no, we have another video about movements, but this is what we're using this hinge joint in order to dorsiflex our foot and plantar flex our foot. You know, bear with me. I'm going to skip around a little bit in this. If I'm going to show you examples of these joints, it sounded like it would be a good way of flowing, but if I'm going to talk about movements at the same time, let's skip down to movements and we'll come back to this part. Because I think when we talk about joints, that goes hand in hand with movements. And let's talk about movements, and then we'll come back to those examples of joints. Angular movements, meaning to increase or decrease the angles between bones. Flexion is to decrease the angle. Maybe have the angle at 120 and move it to 90 or to 40 degrees. Bear with me here. So flexion. Then I'm going to change the color. I don't like doing that color on this. Flexion is to decrease the angle. So if the angle was at 180 degrees, meaning it was planar, when we flex a joint, we decrease it from 180 to maybe like 90 degrees or to like 40 degrees. Sorry, I've got cat hair around me. The one thing about not having my little puppy teaching assistant here is my cats like to sit on my lap during this class. And then I've got hair in my face. So flexion meaning to decrease the angle of in between the joints. Extension meaning to increase the angle between the joints. So initially the angle was 90 degrees. Well, let's increase it to where it's 120 degrees. So now it's like 90 degrees approximately. We extend it towards 180 degrees. So increase the angle. Or extend angle. Hyperextension. Meaning to increase the angle between the joints beyond beyond 180 degrees. So maybe to like 200 degrees. So increase the angle beyond 180 degrees. So I don't know if you can do this with your elbow. You may not be able to do it, but the kind of, not very well. Can't really hyperextend your elbow. Why can't you really hyperextend your elbow? What's stopping you from being able to hyperextend your elbow? What do you think it is? What's stopping you from being able to hyperextend your elbow? that trochlear notch, that calcaneus trochlear notch is preventing you from being able to hyperextend your elbow. Because you're going to run into that. What's preventing you from hyperextending your knee? Somebody tell me, what bones are involved with your knee and what's preventing you from hyperextending your knee?
The patella, the femur.
Yeah,
and then
the patella is preventing you from being able to do that, thankfully. Because I've heard it, people do it and it hurts. Lateral flexion, flexing away from the midline. Lateral flexion, you're standing like this and you do this. I'm at 180 right here, standing straight. When I flex off to the side, I'm lateral flexing. Adduction, what does it mean to add something to something else?
You move toward the midline?
Yeah, you move towards the midline. So if I want to adduct my arms, I bring them to the midline. I can do the same thing with my fingers. What does it mean to abduct a child? Really kind of, yeah.
Take away.
Yeah, take it away from the midline. So abduction meaning I can abduct my arms. I can abduct my fingers. Adduction, abducting. Circumduction, what do you think circumduction means?
Move in a circle.
Yeah, moving in a circle, circumduction of my shoulder joint. Circumduction of my elbow, of my hip joints. You can't see that, but I'm doing it kind of. So flexion of the neck, extension, you're at 180 degrees, straight up and down. Flexion of the neck, meaning you reduce the angle. Hyperextension, pushing it beyond 180 degrees. You can do that because there's no bone there to prevent you from hyperextending your neck. Your elbow, flexing it and extending it. Flexing it, reducing the angle from 180 degrees to something else. Extending it, meaning increasing that angle. Your knee, the same thing. When your knee's extended, you're at 180 degrees. When you flex it, you reduce the angle here. So it goes from 180 degrees to something less than 180 degrees. Same thing with your wrist joint. You can hyperextend it. Let's see here. Hyperextend. So right now, I'm extended it. Can hyperextend it. Can flex it. Can extend and flex my trunk. When I'm standing straight, I'm moving it to 180 degrees. I'm 180 degrees. I can flex it by moving down. I can also hyperextend it a little bit, depending on just how flexible you are. Lateral flexion, meaning flexing off to the side. Laterally, meaning to the side. Abduction, abducting your arm, adducting it, bringing it back. Abducting your leg, taking it away from the midline, adducting it, bringing it back. Can adduct and abduct your wrist. Abduct and adduct your hand, fingers from your hand. Circumduction, making a circumference with your arm or your leg. That's the way I think of it. So rotational movements. Any questions? Before I just keep going forward, any questions? Rotational movements. The atlantoaxial joint, that's that pivot joint between the C1 and the C2 joint, vertebrae. Being able to do this, lateral rotation, medial rotation. We're coming back. Bear with me. Lateral rotation, moving my neck to the side. Medial rotation, bringing it back. Pronation with my prone. When you're prone, what does that mean? It means that your back's towards the ground, right? Your back surface is on the ground. Supination, meaning your stomach is on the ground. So with your hand, pronation, the silly way to remember it, and this is the way I remember it. Actually, this is supination. This is supination. This is pronation. And the reason I know that, and the reason I got it mixed up before, is because supination means that you're holding a bowl of soup in your hand. Pronation meaning you're more prone to spill it. That's the way I remember them. Pronation meaning that your stomach's on the ground.
I don't know if there's anyone out there that takes yoga classes, but Supta Baddha Konasana is supine bound angle. So the supta is the supine, and bound angle, you're laying on your back, so it's like a butterfly. So you're laying on your back with your feet together, knees out to the side. Anyway, that's good teacher training coming out.
Wow. No, I don't take yoga. I do one yoga pose because it's good for the curve in my lower spine. What do they call it? I think it's called the shoot, what was I told it was called? My one little niece calls it the Superman pose because that's what they teach her in her gymnastics class. But I think it's also called like the walrus pose or something to that effect. Otter pose, something like that. Where you lay down and elevate your feet, and you're lay down so you're on your stomach, and elevate your head and your feet.
It's been a little while since I taught, but
Do you know what I'm referring to?
back it would be locust. But yeah, I know what you're talking about.
It works really well. I have a curve in my lower spine that's moderate to severe. Actually, it's more mild to moderate, somewhere in there. And I just know that I need to work on my ab muscles and work on strengthening my back muscles. And it doesn't hurt if I do that. So lateral rotation, meaning to rotate off to the side. Medial rotation, rotating towards the middle. Pronation, meaning your stomach is down. Stomach is down, your back is up. Supination, meaning that your back is down and your stomach's up. With your arm lateral rotation, moving your arm off to the side and immediately bringing it back. Lateral rotation, moving it out to the side. Medial rotation, bringing your foot back. So depression, bringing your scapula up, elevating your scapula, depressing your scapula. And then putting them down again. To protract or retract your jaw. I can't do that anymore very well since I broke my jaw. Because when I messed up both of my TMJ joints, I messed up the ability to do that very well. But essentially it means protracting, retracting, bringing it back. You can probably do it better than I can. Oh, let's see here. What else was there? Dorsiflexing and plantar flexing. Bear with me here just for a second. Working in a very tight space, but we're going to try. There. Let's see here. So dorsiflexing. Here's my foot. Dorsiflexing. Dorsiflexing meaning that I'm bringing the back of my foot up towards my shin. Plantar flexing. Putting the bottom of my foot down. Dorsiflexing, trying to get the back of my foot, because what's the back of your head? The back of your head is this. So the back of your foot is what you're looking down at. And so I remember it best by thinking, okay, I'm bringing the back of my foot up to the surface of my tibia. Another way to, so that's the way, okay, so dorsiflex, meaning to bring the back of your foot to your tibia. Plantar flex, if you wanted to plant a seed with your toe, your big toe, you could push down your big toe in the dirt and make a little hole and put a seed in it. That's the other way to remember plantar flex, or just remember it's opposite of dorsiflex. Inversion, eversion. Oh, that's another one. Bear with me one more time. Get to see my feet one more time. No, I don't have ugly feet, and I know that I've got socks over them, so we're good. Inverting your foot. Oh, of course, you still can't see it. Inverting your foot, bringing the inside of your foot to your middle. Everting it, bringing it out to the side. Inverting, everting. All right. I think I'm giving up because I don't think that really helped. I hope it helped, but I don't know how much it helped. The only opposition that I know of is when you can oppose your fingers. Oppositional. Being able to bring your thumb and your little finger to the center. Because we have opposable thumbs. Why are you doing that? Now, so those are those same movements that I just tried to do. Let's watch this video. I will let you go early tonight. I think I should try more to give you more time to work on the labs when we have lab time. And so bear with me just for a second here. Got one more short video, and then I want to look at these examples of joints, and then we'll be done for tonight. Where was I? So anatomical movements. No, you can't be up there, buddy. No. Yeah.
We can't wait to be doctor. Welcome to anatomical yoga. We'll start at the top of our mats in anatomic position. Gently elevate and retract your scapula with ever so slight cervical circumduction. Now, flex your dominant hip and knee while an externally rotated contralateral hip and flex knee allow you to rest your foot on your thigh. Next, we'll move on to my favorite, the downward Vesalius. If none of that made sense, then keep watching this video because today.
Elizabeth, I'm sure your yoga is much better. I didn't realize, I forgot about the fact that he was going to make fun of yoga right there.
Hey,
That's okay. We have sense of humor.
What's up, y'all? My name is Pat Kelly. I got another anatomy lesson for you. Today, we're talking movement terms. These are all the motions as they apply to the body. So we're going to go over what those movements are, what joints they apply to, and give you a few memory devices so hopefully you can remember them. I made this video to accompany my anatomical regions and directional terms videos. So if you haven't seen those, I'd recommend clicking that link right there to get a little bit of background. So here's the big picture. We have multiple joints that all move in incredibly unique ways. So simple terms like up, down, and sideways don't apply here. We need unique terms to describe unique motions. And when we're talking about anatomical motion, we reference an imaginary body in something called the anatomic position. That's standing upright with feet forward, arms by your side with palms forward, and head neutral looking forward. I've said it before and I'll say it again. Always refer to the anatomic position whenever you're talking about direction or motion. This is forever and always your starting point in anatomy. Why? Well, it's tempting to say something like move the patient's leg up to refer to hip flexion when someone is in the anatomic position. But that's a completely different motion than if they're lying on their side. So in order to standardize language, we always refer to the anatomic position. The second thing to keep in mind is that there are different planes of motion and different axes of motion with which these limbs and joints move around. Obviously, your body exists and moves in 3 dimensions. So while some motions seem like they happen in a very straightforward linear way, most day-to-day motions are a combination of those. Let's start with abduction, which is movement of a joint away from the midline of the body, and adduction, movement toward the midline of the body, specifically this midline on the sagittal plane. Now, clearly these words sound very similar, and some folks will painstakingly spell it out abduction to make it super clear. But the difference is actually way easier to remember. I picture an alien abduction taking my arm away from me, whereas with adduction, I'm adding to the size of my body. You'll see these motions all the time with shoulders and hips, but you can also apply them to fingers and wrists. In those cases, abduction doesn't necessarily mean going away from the body's midline, but from the midline of the hand. So really, finger abduction is the same thing as spreading your fingers, while adduction is closing them. One little note though, some clinicians will call this motion wrist abduction or adduction, but some will say radial deviation, meaning the hand is moving towards the radius, or ulnar deviation toward the ulna. They're the exact same thing, but since the hand and wrist are so often not in anatomic position, they're easier to remember this way. Next up is bending and straightening. More technically, flexion, which is a decrease in the angle between 2 joints, and extension, an increase in that angle. It's pretty intuitive for joints like the knee, elbow, or even spine, but some joints are a little trickier. Like this is shoulder flexion, and to me, it just looks like my arm is going away from my body. So I had to come up with a separate way to remember flexion versus extension. I remember that flexion is like the fetal position, which clearly both start with F. Check it out. The hips and knees are in flexion, the shoulders, elbows, and wrist are in flexion, and the neck and all parts of the spine are in flexion. That's right, flexion and fetal, the 2 best F words for any memory device. Extension is the opposite. You're increasing the angle between 2 joints, which usually results in straightening the limb or extending it past that frontal plane midline. But be careful because flexion and flexing are 2 very different things. When we say flex a muscle, what we're actually saying is to put tension on it, to contract it. And yeah, when you're flexing your bicep, you're also doing elbow flexion, but you can flex your quadriceps while you're extending your knee. Got it? Rad. Moving on. Next up is medial and lateral rotation, sometimes called internal and external rotation. And just like picturing rotation from physics, we first need to figure out what our axis is. So for both the shoulder and the hip joints, our axis is going to be an imaginary line running through the long bone of those joints. You can do this with me. If you stand up and lock out your elbow and rotate your shoulder so that your thumb starts pointing towards your midline, you've medially or internally rotated the shoulder. Now on the flip side, the thumb is heading back out, so we're doing lateral or external rotation. Same thing with the hip joint. If you stand up and lock out your knee, when the foot goes towards the midline, that's medial rotation. If it goes out, lateral rotation. But remember, movement terms use the anatomic position as a reference. So if we're in standing, we can get away with using our hands and feet as little guides, but that might completely disappear if we have our person change position. Like, imagine for whatever reason you wanted to assess a patient's internal shoulder rotation in a seated position. It's going to be really difficult to work with a straight arm, so you have your patient bend their elbow. Now, in this case, internal and external rotations still make intuitive sense. My arm is going toward the midline or away from the midline, which agrees with the long axis rotation we defined earlier. That's awesome. Unfortunately, that doesn't translate to the hip joint. Right here, I'm actually doing medial hip rotation. The long axis of the femur is rotating towards the midline, but my lower leg is all out to the side. Vice versa when I do lateral rotation or when you test this in the supine position. Okay, lesson learned, if you look at the long axis of the bone in anatomic position, you'll never trip up. So those are our major multi-joint movements. But there are some exceptions, and from here on out, it gets pretty specific. Like the radius has the ability to flip around the ulna due to a cool little pivot joint between the radius and ulna that's totally separate from shoulder rotation. This is called supination and pronation. Supination, everyone remembers because you flip your hand up like you're asking for soup. It gets dumber. On the other hand, I remember pronation because it's like a bunch of pro national football players all putting their hands in on the pile. Also, can I get credit for putting literally the other hand in? But it gets even weirder and more specificer. Like the ankle joint, specifically between the talus and the lower leg, do something called dorsiflexion and plantar flexion. I remember these because when you point your toes down, you're planting your toes on the ground. Then when you point them back towards you, you're pointing them towards your dorsal aspect, your back, where we keep our dorsal fin. But the ankle can still wiggle a little more. That same talocrural joint rotates around the long axis of the metacarpals to do inversion and eversion. Easy way to remember those, if you invert your feet, your body will trip over and your body will end up inverted too. But you could forever comfortably stand in eversion. We're getting to the end. Lastly, we need to look at the scapula. They can elevate or depress, protract or retract, all of which are pretty intuitive to remember. Finally, we have circumduction, which is this big, silly looking circular motion that happens at a few joints, including the neck, shoulders, and hips. Now, those are all the major motions, but there are a couple things to keep in mind. As a clinician, you're probably going to care about these movement terms because they're going to help you document things like range of motion and functional movements. Usually, we care about three types of movement. Active motion, which means the patient is moving the joint through their own efforts. Passive motion, which means the motion is being done to them either by your hands or by a machine, and resisted motion, which is self-explanatory. Some kind of resistance is being placed on that motion. And those are important distinctions to make because that might help you with your assessment. For instance, if somebody had painful active shoulder flexion, but they were fine on passive shoulder flexion, you can use that information. Now, all anatomy students are going to need to know these movement terms, but if you're more interested in movement itself, I'm going to recommend this playlist up here. It's my musculoskeletal biomechanics and kinesiology playlist. Specifically, I'm going to recommend this video about origins and insertions. I think it'll be really helpful to you. And a big thank you to David, who's my newest patron on Patreon. If you want to join him, you can click that link there, or you can support the channel for free by subscribing at that link there.
Okay. Let's move back. Any questions about the movements? Okay. Now, Elizabeth, you're the only one that I can say right now. So if you say no, then we don't do it. Of course, it takes us to the very beginning. No, it's not as far. Didn't want to go that far. So hinge joints can flex it. You can flex it. You can flex the knee, dorsiflex a foot or plantar flex a foot using this hinge joint. Cuneo-navicular joint between the cuneiforms and the navicular bone. A planar joint. Same as that of the between the carpals. Ball and socket, when you're identifying those figures, using the looking at the figures and trying to figure out what the answers are, I specifically picked these photos so that you could figure out the right answers. And I added some things that added some labels that weren't there for that reason also. So the head of the humerus articulates in the glenoid cavity. The little glenoid labrum, meaning the glenoid lip, right here. The acromioclavicular joint between the acromion of the scapula and the clavicle. Leo, you can't be up there, bud. No. The head of the femur in the acetabulum. Looking at a frontal section. Trapezial metacarpal. So between the trapezium and the metacarpal, this is that saddle joint. And the hinge joint between the radius and the ulna and the carpals. And the planar joints between the carpals. Probably the best hinge joint ever, the knee joint. The patellofemoral joint. All of the ligaments that are involved in the knee. Have medial collateral ligament, the MCL. The lateral collateral ligament or the fibular collateral ligament. Anterior cruciate ligament, posterior cruciate ligament. What does it mean, cruciate? What does cruciate mean? What does cruciate mean?
Cross-shaped.
Cross-shaped. I'll tell you the way that I remember this, and I am not good into horror films. I don't like scary films. I like intense films, but I don't like scary ones. But I'll never forget the song that goes with, I think it's Friday the 13th movies. Do you know what one I'm talking about? 1, 2, Freddy's coming for you. 3, 4, you better lock your door. 5, 6, he's gonna crucifix. You know what I'm talking about.
Yeah, it's really creepy.
See, that's I've never watched them for that reason, but I know the song. So anterior cruciate, we're looking at the front of the knee. Anterior cruciate is going to come from the inferior front of the knee and wrap to the back and insert in the back. Posterior cruciate is going to come from the back of the knee and wrap around to the front. So that's your ACL, your anterior cruciate ligament, your posterior cruciate ligament. Your medial collateral ligament, or your MCL, your LCL, your lateral collateral ligament, or your fibular collateral ligament. The medial collateral ligament is also called the tibial collateral ligament. But everyone has heard of someone who's done something to their knee, blown out one of those ligaments. That's what they've blown out. Looking at a sagittal section through the knee. Articular cartilage. The bursa that you don't really see, but they're little sponges of fluid. All right. Do you guys have any questions for me?
That last picture there, can you see the synovial joint or the synovial, like
Fluid?
you know what I mean? Yeah, is it visible here, or is it because it's a
Really, and I
cadaver?
think it's because it's fixed.
I see.
If once the person dies, all of those ligaments and tendons start breaking down and the fluid leaks out. But it would fill up this little space right here.
I see.
One thing that we could do, I can let you go. I'm willing to let you go tonight, or I can sit here and start working through the lab with you, the lab questions. What would you like me to do? Because I think we're going to be fine getting through the lecture material without doing more tonight.
I'm fine with going.
Okay.
I would love to take my dog for a walk. I vote, yeah, that we're good.
Thank you.
I third that.
I need to pick my daughter up from field hockey soon, so.
If you want to leave, feel free to leave, and I'll be the last one to leave. So if you stay, I'll start working through it. But if you need to leave, feel free to leave.
Thank you.
Thank you. Have a good
Thank
night.
you. Have a good
Thanks.
night.
Have a good night.
Thank you.
Thank you.
Thank you, Professor.
Of course.
Which lab are you working on?
The lab exercise 11. Is there another one you wanted to work on?
Let me make sure. I just want to make sure I did it.
I just had a quick question.
Okay.
On Monday, I was logged in on my phone, and I don't know if it showed my name. Did you take attendance for me?
No, I didn't. You know what? I only take attendance. I'll tell you, I only take it at the very beginning of the semester.
Oh, okay.
And
I
when
just wanted to make sure.
Requires, if I don't see you at all, if I never see your name come up, and Jennifer, I think I saw your name come up.
Okay. I wasn't
remember
sure
seeing it.
if it logged in on my phone right on the Zoom or not. And I just thought about it tonight when I saw my name and I was like, I never said anything. I mean, I talked to you at the end, so I didn't know if you knew my voice, but
No, I know your voice too. I think that's part of it too. But you know, if I didn't see you for like a couple weeks, then I would wonder where you were.
Okay.
But I know who you are and I know your voice too.
Okay. Just wanted to make sure. Thank you.
You're welcome.
Have a good night.
You too.
I think I did it.
You did lab exercise 11?
The one with the virtual people, yes. I'm working on the Wiley exercise now.
Okay, well, that's the one I was going to work through. Do you want me to help you with some of it?
Yeah, if you want to. I mean, I was gonna stay on until about 8:45ish, or like work on it till about 8:45ish. Just because I gotta wake up at like 3 in the morning tomorrow.
You know, let's stay on until 8:40 because I have to be up early in the morning. And I'll tell you, my Thursday nights are really, really late. So let's stay on until then.
Sounds like a plan for me. Okay, that makes me really happy that you don't take attendance every class, because I know I've been missing a lot of lectures.
There's internet issues. There's all sorts of reasons what can be going on with people. I mean, some people have little tiny kids and for some reason they can't be here right at that moment, and that's fine.
Okay, that's good.
It's the stuff of being in an online class.
That is a big positive. I just hope that my next semester's class is like, he's not so hard on it, you know, because it's all of it is online now. It's all online.
Who do you have next semester? Do you know?
Chavez, I think.
I've heard the name, I think, but I don't know if I know who it is.
Hold on, let me double check. It's not a night class. It's like Thursday afternoons. It's like a 4-hour class.
Okay.
My geeks.
So looking at this first one, where do you think the ligament is?
Let me see. Sorry. Okay.
What bones are those?
So let me get back up to chapter 1. So that looks like the knee joint.
Not exactly. It's more the arm.
Is it the elbow?
Yep.
Okay. So number 1 is the head of the radius.
Okay.
So the top one, the first one that you see is head of radius.
The head of the radius is right here. Bear with me here. Come here, you. Right here. Okay. Oh, that's not it. That the head of the radius would be right here.
Okay. That's the radius. The head of the radius is the blue thing.
Okay.
And then the annular ligament is the white thing.
Okay.
Radial notch is the arrow that's pointing to the other side of the blue. So on that side on the top.
I think that I've got these mixed up. This goes over here because I think it's going to this. Or actually, I think this is, you can tell I'm not looking at the answers either. I think this is going to this. That's going to that. And this is going to radial notch right here.
I've already taken this question. Like I've already done this question.
Oh, are you? So you're just telling me what the answers are?
Yeah.
Really? All right. So, wait. So am I going to get it wrong?
The radius and the head of the radius is opposite.
Oh, okay. Let's turn them back. Okay. There. Submit answer. It's only partially correct.
Oh,
The radial notch. Okay, so it's saying that the saying that that's the radial notch. I thought the radial notch was there. Okay, flip those and then they're right.
yeah.
But even though that isn't right, this is the radial notch. The radial notch isn't right there. It's right here.
Huh.
Yeah, just for future reference, it's not right there. That doesn't look right at all.
Yeah, I noticed that like some of the questions will be like on their own Wiley book.
Yeah.
Will be like named different, and then when you try to do this one exactly like how they have it, it will mark you wrong.
I can understand why that's frustrating. Okay, so where are we going here? What one's first? What's top one?
I have a question.
Go.
It's for the virtual lab time to fatigue. I already started, but I don't know how to do the last step. Calculate the time to fatigue and record in lab data.
I think.
I don't know if I can show you my screen for a second.
Yep, let me show me your screen.
That's the only question I have to keep going.
Let's see here. Stop sharing. Okay, go ahead.
Let me share it. I already did this.
Okay, so why did it not let you go forward? You have to calculate the time, the bottom?
Yeah, but I don't know how to do it.
Okay, let's see here. Calculate the time to fatigue and record in the data.
Yeah, but how I'm going to calculate like
Number of active units.
like 4 plus something or how?
Bear with me. Let me look at it just for a second here.
Okay.
Try putting in 29 seconds. See what it does. Type in 29.
No, it's not.
Not that. Is that the correct time for fatigue?
I already add like those numbers. Also these ones.
Do me a favor, go back. Can you go back to screen? Go back to screen.
To which screen?
Go back to screen. Can you go back one screen? No, not there. Can you go back to the introduction?
Let me see. So I'm gonna exit.
No, do you see where it says introduction? On the left-hand side, left-hand corner, click the introduction. How does it say? In the simulation, you'll measure the force. The purpose of this is to examine the time of fatigue. Time to fatigue is defined as the amount of time it takes for a muscle to decrease to 50% of its maximum strength. Now go back. Let's go back again. Now that we know what it means. Can you just bring up your data again?
Yep.
So maximum 48. Is it 60 seconds? Try 60 seconds. No, not 16, 60.
Oh, 16. Yeah, but
How did I do that? Because that was half. So your maximum was 48. Your
okay.
maximum was 48. How do you get to half? Half of 48 is 24.
Okay. And then
Well, now, so click it and see if it says it's correct.
yeah, it is correct.
Okay, so now go to phase 3. See if it'll let you go to phase 3.
Yeah.
There. So go to the next phase. Select the variable for X. What was the experiment? Tell me, what was the experiment?
Number of active motor units.
Or was it time? What were you?
Oh.
Go back and look at the last thing. I go back and look at the last slide. Go back and look at pull up your data again. So this is force is your X variable. And Y or time is. Did you adjust your force or did you adjust your time?
Force.
So your force has to be the one that you can change is your independent variable, and that goes on the x-axis. Your y variable is your dependent variable. I'm just asking you to graph your data.
Okay.
So what one did you change on that last one?
I'm sorry?
What one did you change? Looking back on what you just did to get all these numbers, what one did you change? Go back to the last slide where you actually did the experiment. So increase the grip strength to the maximum force. Click play to start the screen EMS. As 0 seconds, measure the force count number of active units and record in the data. So the motor units is, and motor and count number are your, force and count number of active units is what you changed, right? Or what you were going to measure.
Yeah.
So time is on your x-axis and force and active motor units is on your y-axis. So leave that when time is right. Now what's your next one? What is it? Was that force? What were your other options there? Okay, go with force first. Go with force first, like what you had. Now, what kind of graph do you think you should make? Should you make a line, a bar, line, or pie graph?
Bar.
Okay, so select line, not bar graph, select line. Now click create. See where it says create? Graph, create.
Yeah.
Right.
I already created, and this what is appeared.
It didn't allow you to create it. Did you click the create button? Do you see where it says graph?
Yeah, I already clicked there, but look, this is what it pops up.
But it doesn't look like it actually created your graph.
But this is what it pops out, pops up, like force 0, 10, 20, 30, 40, 50, 60.
Did you click create?
Yeah.
All right, you must make all graph selections before creating the graph. What else do you need to do? Select the graph line, create graph. What have we done wrong? Oh, select graph type. So for some reason it didn't, so put line in there again.
I think we have to do all of
Oh,
that.
you're missing your variables. You have to re-put those in. Somehow they went back to 0. You see under what x-axis and y-axis, they're both, you have to reselect them.
Time, force.
Now click create. Select a different graph. So select, you've got bar graph, you need a line graph, remember?
Yeah, yeah, this is what I got. And save, maybe.
Did you click create?
Yeah.
I didn't see us click create.
Yeah, I click create, look, and then this is what I got after.
But I didn't see you actually click create. Where are you clicking create?
Here.
Your mouse is above it. It's not on it.
Look.
You see where it says graph?
Yeah.
Not up there. Not up there. Right next to graph type, it says graph.
Yeah.
And then it says create right underneath it.
I already click it and this.
All right. I just don't, I guess I'm not, your mouse is like way above where it says to click on it. And that's what I'm
No,
confused with.
look, for example, when I hit create, this is what we get.
You have 2 different mouses. Do you see that?
That's weird.
I don't understand how you have 2 different mouses.
That's weird. Well, I did something. I don't know.
Yeah. Based on the trends you see, what can you conclude about the relationship?
Decreases over time due to an increase in water units.
Why don't you click it, see what happens?
No.
Okay. So do another one, select a different one.
Yeah.
Yep. Congratulations, so you finished the lab.
Oh my God.
Okay.
So you let me stop sharing.
All right, I'm gonna go back. We'll go back and work through one more problem or so with the questions here. So I think those are the answers, Lauren. Did you already have the answers?
Yeah, pretty much. I mean, I'm on question 41 of 70, so.
41?
Yeah.
I'm trying to get there. Come on. 1, 2. All right. What type of joint is that? What's the type of joint between your elbow? What is it?
Looks like it's a hinge joint.
Okay, so type in hinge. Hinge. Smart answer. Ta-da! All right, what's the next question? What kind of joint is that?
It looks like it's the hips, and those are considered ball and sockets, right?
Right. I don't know how it's going to want us to type in ball and socket. So let's see. Ta-da!
Okay.
All right, now you get to just put multiple choice.
Yeah.
You'll never forget. Which one has the least amount of movement?
It would be C, I think.
Ta-da!
Are we doing,
Greatest amount of movement. What one?
are we doing chapter 11? Because it
We're
is
doing lab exercise 11, the one that we just went over with the PowerPoint.
no. I mean, chapter 11, muscular tissue is.
We're gonna do that in lecture. We're gonna do it last.
Okay, because it is after the chapter 16.
Yes.
Okay. I just want to know because it is after the number, you know that.
No, because joints, you want to do joints before you do muscle.
Okay.
You want to, you got to understand, if you're going to understand the actions of muscles, you have to do joints.
Okay.
What's the answer?
D?
What?
D?
D is in Delta?
Mm-hmm.
Okay.
Oh my God.
Yep.
Yes.
Booyah. Which one is slightly movable?
D?
Yep. Which one has a articular capsule around it?
B?
A C or B?
B. I don't know.
B is in Bravo?
Yeah.
Okay.
I'm not sure. Let's see.
Nope, you're right. Which structural joint category has the cartilage joining the ends of the articulating bones?
A?
Is it A? What if it's cartilage?
No. Oh my God.
What do you think it is if it's cartilage joining the ends of the bones?
Oh my God. I'm not sure. I don't know.
Well, look at the names. Well, one has cartilage in it.
Well, B.
Okay, so say B. Let's see B. Yep. Don't make it too difficult. Make that be your first guess. Synovial joints have a joint cavity, true or false?
True.
Yep.
There is one lab that is no open. I think is the last one.
You got to say it a little louder, Kisbel.
That there is another virtual lab that there is not like open. So
they should all be open. What one are you referring to?
It's called virtual lab, muscle physiology, skeletal muscle.
Okay, they're all open. They should be.
Oh, that is the only one that I do not have. Like,
bear with me here. I'll look and I'll tell you.
The last one. It's after the physiology, motor unit.
What one is not? Oh, that one. Okay, you're right. It isn't open. Open it right now.
Okay.
Yeah, you're right. It's not open. Oh, come on, you. All the way to the bottom. I gotta stop sharing for a second. It won't let me do that without. All right, 20 rather than make it the 28th, let's say 13th. And let's have it open at 9 p.m. Okay, it will open at 9 p.m.
Okay. So,
Okay.
Have a good night. Thank you.
You're welcome.
This EMG looks like an EKG, so keep trying to read it like an EKG.
Don't try to read it like an EKG. It won't work.
No, I kind of figured because I was like, wait, this looks like AFib.